Hey everyone, this is Misha, and for this presentation we'll be talking about the research, symptoms, diagnosis, and treatment of insomnia disorder. First, what is insomnia disorder? Categorized as a sleep-wake disorder, insomnia disorder is diagnosed among individuals who experience recurrent poor sleep quality or quantity that causes distress or impairment in important areas of functioning. They can also experience difficulty initiating sleep, staying asleep, and/or by waking early in the morning and being unable to fall asleep. The general symptoms of insomnia disorder include unhappiness with the quality or quantity of sleep, which can include trouble falling asleep, staying asleep, or waking up early and being unable to get back to sleep. The sleep disturbance causes a significant distress or impairment in functioning, such as within the individual's working or personal life, which can affect them behaviorally or emotionally. Difficulty sleeping occurs at least 3 times a week and is present for at least 3 months. The problem occurs despite ample opportunity to sleep, and the difficulty cannot be better explained by other physical, mental, or sleep-wake disorders. The problem cannot be attributed to substance use or medication either. Now, according to the diagnostic criteria in the DSM-5, the first criteria for insomnia disorder is a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms. First, difficulty initiating sleep. In children, this may manifest as difficulty initiating sleep without caregiver intervention. For example, a child might not be able to go to sleep without their parent being present in the bedroom. Also, difficulty maintaining sleep, characterized by frequent awakenings or problems with returning to sleep after awakenings. Also, early morning awakening with inability to return to sleep. The second criteria is sleep disturbance causes clinically significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. The next 3 criteria go into the duration of the lack of sleep. Sleep difficulty occurs at least 3 nights per week. It is present for at least 3 months and occurs despite adequate opportunity for sleep. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder, which means insomnia cannot be grouped in with another sleep-wake disorder such as narcolepsy, a breathing-related sleep disorder, a circadian rhythm sleep-wake disorder, or a parasomnia. The insomnia is not attributable to the physiological effects of substance such as drug abuse or medication. Also, insomnia disorder, coexisting mental disorders and medical conditions do not adequately explain it. Now, there are specified insomnia disorders. The first 3 applies to non-sleep disorder, mental comorbidity, and substance use, other medical comorbidity, and other sleep disorder. The reason why these are applied under this disorder is because insomnia is associated with mental disorder, medical condition, or other sleep disorders immediately after the code for insomnia disorder in order to indicate the association with it. The other specified insomnia disorder is the duration. There's episodic, where symptoms last 1 month but less than 3 months. There's persistent, symptoms last 3 months or longer. Recurrent, where 2 or more episodes within the space of 1 year, and acute or short-term insomnia, which lasts less than 3 months but otherwise meeting all criteria of insomnia disorder. Research on insomnia disorder have shown that people with it often experience tiredness or sleepiness in the daytime as a result, along with related inattention, irritability, and trouble concentrating on tasks, sometimes to such an extreme that their work or social life suffers greatly. It has also been shown that insomnia is strongly associated with psychiatric disorders and can be primary or secondary to a mental disorder. Now, the statistics of insomnia include about 1/3 of adults report having experienced symptoms of insomnia, with 10 to 15% recording daytime impairments. Between 6 to 10% of individuals meet the criteria for insomnia disorder, which is the most common known sleep disorder. Comorbid condition with another medical condition or mental disorder, such as 40 to 15% of individuals with insomnia also present with a comorbid mental disorder, and chronicity rates range from 45% to 75% for follow-ups up to 1 to 7 years. Prevalence of insomnia disorder is more among females than males, with a gender ratio of 144 to 1. They're more prevalent among middle-aged and older adults. For the women, this is thought to be because new onset insomnia may occur during menopause and persist even after other symptoms like hot flashes have resolved. And why it's more prevalent among middle-aged or older adults can be partly explained by the higher incidence of physical health problems that comes with aging. Now, the assessment of insomnia is usually done by a doctor who notices the sign by specific symptoms told by the patient. Insomnia screening includes questions such as trouble falling asleep at night, lying awake for long periods of time, waking several times during the night, waking up early and unable to go back to sleep, not feeling refreshed after sleeping, feeling fatigued or sleepy during the day, having difficulty focusing on tasks, and feeling irritable. Other screenings can include self-report, sleep diaries, Epworth sleeping scale, actigraphy, and polysomnography. The last two are diagnostic tools to check on the sleep patterns of an individual. Now, there are different manifestations of insomnia. There's sleep onset insomnia, which is also known as initial insomnia, involves difficulty initiating sleep at bedtime. There's sleep maintenance insomnia, which is also known as middle insomnia, that involves frequent or prolonged awakenings throughout the night. There's late insomnia, which involves early morning awakening with the inability to return to sleep. And there's difficulty maintaining sleep, is the most common single symptom of insomnia. The reason for this is that the specific type of sleep complaint often varies over time. Individuals who complain of difficulty falling asleep may at one time later complain about difficulty maintaining sleep, and vice versa. Now, for the causes of insomnia disorder, there is no single cause of it, but many factors may contribute to the condition's onset, including stress and anxiety, which can make sleeping difficulty because they are feeling worried about certain situations. There are other sleep disorders that can, like sleep disorders may cause insomnia or coexist with the condition. Like, say, for example, an individual has sleep apnea. This will cause them to wake briefly but repeatedly throughout the night. There can also be mental disorders which coexist with insomnia disorder. Mental conditions such as depression may contribute to the onset of insomnia disorder, and vice versa. Medications or substance abuse. Some medicines to treat a condition can have an annoying side effect of insomnia. Lifestyle factors such as working late and consuming caffeine or alcohol can make sleeping difficult. Or comorbidity. As stated before, insomnia can occur independently or can be comorbid with other conditions, which can be medical or psychological, for example, heart disease or bipolar disorder. With the differential diagnosis, insomnia disorder shares many similar signs and symptoms with various other conditions, so it can be difficult to diagnose. The most frequent diagnoses with insomnia disorders are normal sleep variations that has similar symptoms of insomnia, but they can still have a good night's sleep. There's situational acute insomnia, which only occurs for a short time. Delayed sleep phase and shift work types, which is because of environmental factors such as changing your work shifts. Restless leg syndrome, breathing-related sleep disorders, narcolepsy, which do share characteristics with insomnia, but often have other features like sleep paralysis or sleep-related hallucinations, parasomnias, or substance medication-induced sleep disorder, which certain medication can have the unknown side effect of insomnia. Now, the treatment for insomnia are unique for every individual. One can work for one, but not for the other. Now, the treatments to use can be through medication or with therapy. With the medication, the most popular known are Lunesta, Roserum, Sonata, Ambien, or Ambien ZR. There's also sleep hygiene education, which is the habits and practices that contribute to getting a good night's sleep and include factors like diet and exercise, as well as environmental elements like light and sound levels at bedtime. There's also therapies like cognitive behavioral therapy, relaxation therapy, stimulus control therapy, biofeedback, sleep restriction therapy, and paradoxal intention. Research of insomnia among psychiatric population found that chronic sleep problems have been most commonly reported among those with psychiatric disorders like bipolar disorder, anxiety, and depressive disorders. Approximately 50 to 80% of adult patients with mental illness had difficulty with falling asleep or staying asleep in a typical year. Here is a sample case study of somebody with insomnia disorder. Joanne is a 42-year-old woman, is referred to the Sleep Disorder Center with a complaint of chronic severe insomnia affecting her daytime functioning. Joanne tries to go to bed around 11 p.m. She usually falls asleep around less than 15 minutes, but occasionally it seems to take her hours to fall asleep. She wakes up 3 to 4 times per night. Joanne gets frustrated when she sees the clock ticking away. In response, she usually gets out of bed to work on the computer until she becomes sleepy, which often does not happen until around 5:30 a.m., which is the time she should be getting up. At that time, Joanne falls asleep into a very deep sleep and may not awaken until 7 or 8 a.m. The single mother of 3 teenage boys, Joanne first experienced insomnia 8 years ago when bankruptcy threatened her small business. Although the business recovered a year later, Joanne's insomnia has remained almost unchanged over the next 8 years. Joanne's general physical evaluation found Joanne to be healthy, but suffering from excessive sleepiness, fatigue, and lack of energy. A psychiatric interview revealed high stress levels, but no evidence of depression, anxiety, or other psychopathology. Joanne was referred to a sleep center where her screens for restless leg syndrome and possible respiratory disturbances were negative. An evaluation of her current lifestyle uncovered situational distress and a weak coping style. She has taken zolpidem and zaleplon, as well as several antidepressants such as trazodone. All have been unsuccessful. Although an initial benefit was derived from some of these medications, Joanne gave up on each of them after a few weeks because of their side effects and/or lack of efficacy. Joanne was then recommended the following sleep hygiene improvements: decrease caffeine intake, avoid sleep late in the mornings at all costs, conceal the alarm clock to avoid checking the time during the night, and when she's unable to sleep, to do some light reading rather than working. After 6 months, Joanne's sleep improved, and she reported that she now slept poorly only about 2 nights per week. An hypnotic was prescribed for her to use if her sleep was poor for 2 or more nights in a row, or she anticipated being particularly stressed the following day. 1 year later, Joanne reports that her life has improved, and 5 years later she was sleeping normally without the use of hypnotics. Here was a clear-cut example of somebody with insomnia disorder, what her symptoms was, how some treatments did not work for her, but for others it improved greatly to the point that she no longer needed to use medication to help her sleep at night. And that, everybody, is what insomnia disorder is.